Hello, everyone. I want to welcome you to the Impact Education's PayerTalkCE program, Case Challenge, Type 1 Diabetes Patients who have Diabetic Retinopathy. So I'm your host, Dana McCormick. I am a Senior Director with Optum Insight, which is a consulting division within Optum. Super excited to be here today with you all. This PayerTalkCE program is jointly provided by Medical Education Resources and Impact Education, LLC, and it's designated for half of a contact hour of CE credit. This activity is supported by an educational grant from Regeneron Pharmaceuticals, and so we'd really like to thank them for their support to make this program happen. At the end of today's program, you'll be asked to complete an evaluation, which you must submit in order to receive credit. So you'll just click the complete evaluation in the navigation within the activity. And once you've completed your evaluation, you'll click Claim Credit to download your certificate, or for pharmacists to have your credit submitted to CPE Monitor. I'm very excited today to be joined by Dr. Adrienne Scott. Welcome, Dr. Scott. Thanks so much for joining us. Would you mind giving us a short introduction of yourself?
Well, thank you for having me. I appreciate all. I am a retina surgeon, and I'm a retina specialist at Johns Hopkins, a large academic center, and see a good bit of variety of patients with diabetic macular edema and wet macular degeneration and a variety of diabetic eye disease, as well as things like retinal vein occlusion. I also do some research and some retina surgery, and I'm very excited to talk about challenges of diabetic retinopathy.
So glad that you're joining us today. In particular, diabetic retinopathy is a condition that payers do remain acutely aware of. Not that it's a high prevalence condition, but it is the number one cause of preventable blindness among Americans. And the data does suggest that prevalence of at least diabetic retinopathy is increasing in younger populations in the United States. Of course, it's still something that affects older patients to a greater extent, but working age adults are certainly not immune to it. There are substantial costs associated with the treatment and patient burden as well. I think it'll be helpful for payers to talk about a specific patient case so they can put an actual patient in the context of our discussion, and we'll want to hear your perspectives as the expert in the field. Before we start reviewing the case, can you provide a little background on the disease in terms of presentation, prognosis, and treatment?
Certainly. Thank you so much for the opportunity. And, essentially we'll concentrate on an individual with diabetes and how that can have consequences for what we see in the eye. And certainly these individuals are at risk for vision loss from their diabetic eye disease. We generally kind of talk about two vision threatening problems with the diabetic condition that we see in the retina. One is diabetic macular edema, and the other one is proliferative diabetic retinopathy, when you can have abnormal blood vessels grow. And these blood vessels happen as a result a lot of times because the blood flow the blood flow is not optimal in these patients. Like they get kidney disease and limb disease, and that causes amputations, and small vessel disease, heart disease. Similarly, they have retina problems that can manifest. So certainly these individuals are challenging to treat, in addition to the eye disease they can have, but also because of the systemic manifestations of the diabetes that, the body is connected to the eye, and, there might be multiple organ systems affected by their diabetic eye disease.
Thank you. So let's talk about a patient, just again, so we can put in context all of the rest of our discussion. So I feel like we've got kind of a pretty typical patient that may be coming to your office. She's a 40-year-old female who works as a cashier at a grocery store. She uses public transportation to get to and from work and various appointments or other places that she needs to go. She lives alone and she's on a tight income. She has a 15-year history of moderately controlled type 1 diabetes. Her HbA1c has ranged recently anywhere between 8 and 9%, and she's taking basal insulin, and she also has hypertension. So far, sounding pretty typical, right?
Yes.
The patient is slightly overweight with a BMI of 26. She presented for a second opinion regarding the vision of her eyes, and after complaining to her primary care physician, Although she was worried about missing work for another appointment, still confided in her physician about her vision. Her ocular history included center involving DME in the right eye, and her visual acuity in the right eye is 20/80 and it's 20/40 in the left. So, Dr. Scott, is this typical to what a patient may present to you by the time they get to you? Is this a typical patient?
Absolutely. I have several patients that fit a lot of these characteristics, and it sounds very familiar. So, the blurry vision will eventually have the patient present, usually to a primary care or endocrinologist, a primary care doctor or an endocrinologist, because I feel like those individuals have the most point of contact with the patient per se. And the hope is at that point, while the patient complains of blurry vision, they'll get some sort of referral to an eye care specialist, hopefully a retina specialist, to be able to better understand, or at least a good primary eye care doctor, a comprehensive ophthalmologist or optometrist, to be able to understand, is this something that can be a refractive error corrected with glasses, or certainly is probably the case, this has to do with the individuals having a history of diabetes.
So, Dr. Scott, when you see her for the first time, what is it that you're looking for to determine a diagnosis and to potentially think about the extent of the disease involvement for her?
Yeah, it's a great question. I mean, I think that obviously the one eye is severely, in that visual compromise arena. The other one, not quite as bad, but I think that the first thing you want to make sure of is that the person has had a good refraction, meaning sometimes if a refractive error is present, that can be fixed with glasses most times. However, this individual sounds like they have diabetic eye disease. And so the way we diagnose that is with clinical exam. So we examine the patient in the clinic, and a lot of times we'll do an adjunctive imaging test called an OCT, or optical coherence tomography. And that really clinches the diagnosis of diabetic macular edema. And typically you divide it up. If they have swelling or a macular edema toward the center of their retina, then they're considered to have center involving DME. And if it's off to the side or not necessarily involving the foveal center, it's non-center involving, a lot of times they'll have better vision. So it sounds like the individual unfortunately has diabetic macular edema that's involving her foveal center, which, we can confirm with exam and then the imaging that we do in the clinic.
So I know screening, again, prevention and early diagnosis is the best way to help patients have or prevent, negative outcomes from progression of this disease. And I know payers have all been focusing on how to get patients to actually go get screenings done. And like for a very long time, like I've been in managed care for almost 30 years. And I know it's been something that as, working for payers and health plans, it's something that we put a lot of effort and time in, sending reminders, sending physician reminders, mobile units being sent around. And again, I think as evolving technology that's able to help, with some of the diagnosis is hopefully helping increase screenings. Is there anything that you can think of that payers could do better to help support patients getting screened? I know a lot of education is a lot of it's education, but is there, as you work with your patients, are there things that you think of about from a payer perspective that could help with those patients having their screenings done?
Sure. And I think payers do a pretty good job, generally speaking, with the preventive aspect of it. But the thing that I think we can improve upon is what the patient has to do to get into their primary doctor or endocrinologist and then get to the eye care, into the eye care system. There's some integrated systems that have, various, departments, ophthalmology and retina within that. But then you have some that are not integrated. So it may be private practices that the patient's trying to navigate in between, communicate in between. I think a payer could better help facilitate a visit for a patient into an ophthalmology or ideally a retina specialty clinic. A lot of times I kind of wonder about telemedicine is also kind of one of these newer innovations too, but we can diagnose the eye disease, but how do we get the patient the treatment that they need? How do we get them in the system? in front of the ophthalmologist, retina specialist that needs to be able to see the patient to treat them. So I feel like
Sure.
there's a bottleneck at that point. So anything a payer could do to better facilitate the patient into their specialty care visit would be great.
All right, well, let's move on to the examination and diagnosis. So upon a dilated fundus examination, you see the onset of neovascularization at the inner surface of the retina and into the vitreous induced by a more global retina or retinal ischemia. So new vessels on or near the optic disc and new vessels elsewhere have contributed to the vitreous hemorrhage in the right eye. There's a substantial amount of neovascularization in the left as well. And her ophthalmologist has classified it as proliferative DR or proliferative diabetic retinopathy. So what are some of the things you would look for in your comprehensive examination? And are there any specific markers or indicators of disease that could predict prognosis or help guide therapy?
Yeah, that's a great question. I think at this point, the patient's kind of in a danger zone, and it's a pretty severe clinical scenario when a patient has proliferative diabetic retinopathy. It means, she's been maybe away from the healthcare system more than she should, definitely not getting her eyes checked regularly. It's usually the kind of thing we can see on a clinical exam or clinical imaging if the patient's in front of us. So, this is a patient that's in danger. She's going to have to be treated now, because these abnormal new blood vessels, proliferative diabetic retinopathy, the blood vessels can break, can bleed, cause vitreous hemorrhage. Fortunately, we've got lots of treatments that we can discuss, and we will discuss how to best treat this patient. But their systemic disease, having diabetes for so long, and not having had ophthalmology exam or retina specialist examination has gotten them in a situation where they're in a precarious situation and danger of sight-threatening permanent vision loss. So we've got to treat this person. We can talk about the different permutations and different ideal treatments for different people. Luckily, we have lots of studies to inform how we treat patients, but this is somebody that looks like they're needing treatment.
So when you say needing treatment, what are your thoughts about when you see a patient? Are there times when you feel like there is an urgent need for like immediate treatment at the time that person is in your office? Or are there times where it can be, pushed off to another appointment? And about for this patient that you see, what are your thoughts about her presentation and the need for immediate or pushing therapy off?
Yeah, this person, I try to consider the whole person when I kind of consider the best treatments. Because fortunately, we have options. But one thing that kind of stuck out to me is that we mentioned that this person was really not wanting to miss work, and they were, really concerned about that working age. And that sticks out in my mind, that they're not a person that's going to be pretty regularly at many different appointments for follow-up, or at least certainly that would cause them significant hardship to miss a lot of work. So that said, I would have to kind of get authorization, and that's where we kind of have to work hand in glove with the payer, prompt authorization of whatever treatment I wanted to employ. A prompt authorization from the payers would be helpful, and I don't have to treat them then and there. So, but I'm looking for, within the next 4 weeks, ideally like 2 weeks, if I can be treating them, if not sooner, pending their authorization. If I can start treatment, that would be ideal. So then the patient can kind of get their head around what I've told them. They can bring maybe a driver with them if they have somebody to kind of bring them that day for their treatment, can understand. Maybe I'll give them literature to read about it. I'm sure they'll have questions, or family will. So, we have a little window of where we can treat them, where they can kind of bring a driver and be prepared mentally for the treatment. But I worry always that the person won't follow up. If you say come back in X weeks, then they'll run into some barrier, or maybe some answering service will say, oh, there's nothing available, and then the patient will kind of be like, oh, forget it, or they'll get discouraged and not come back in.
Yeah. So once the treatment phase has begun, we'll continue talking about this patient and see how this patient was managed. So after she was diagnosed with wet diabetic retinopathy in both eyes, it was recommended to begin intravitreal anti-VEGF immediately to preserve her vision. Bevacizumab was first-line anti-VEGF in the step therapy protocol for the patient's marketplace plan. The ophthalmologist treated her with bevacizumab at the first appointment, knowing that the cost would be minimal to the patient, even if there was a problem with her insurance. The patient was concerned about her ability to continue to get to the office monthly based on her situation, and expressed that concern to the physician. And so the ophthalmologist told her she would submit for an approval of an anti-VEGF agent that could be extended out to 12 weeks eventually, again, as long as her diabetic retinopathy stabilized or improved. So, Dr. Scott, what other medical policies are you seeing in place regarding anti-VEGF therapies, and how have step therapy requirements affected your own clinical practice, specifically as it relates to patients having access and in time to be treated appropriately from a time perspective?
Well, step therapies have definitely impacted our practices as retina specialists, meaning that we are kind of used to treating with whatever we want to treat them with and having a discussion with the patient, of course, and, looking at the studies and making that decision. Now, we have to make sure the patient's payer will cover the treatments, whatever treatment we recommend. So, that's that's their full-time job to make sure that the patient's payer will authorize whatever treatment we are going to prescribe. I think bevacizumab is a completely reasonable treatment. It affects and treats both the proliferative diabetic retinopathy and if there's any diabetic macular edema component as well. Now, I do find the bevacizumab a little untenable as far as I think the half-life is it wears off after about 4 to 6 weeks. So I think it's a little untenable for somebody that has angst about missing work or needs to be at work and can't come for appointments that frequently. So I think a more durable agent is completely reasonable after showing some benefit of bevacizumab. More durable agents include things like aflibercept, and I would start with maybe aflibercept 2 milligrams. I think that's a reasonable call as well. If the payers oftentimes they'll create what's called a step therapy, or they want to see failure, which is kind of a weird term, but they want to see that, okay, you use off-label bevacizumab for this eye disease. Show me evidence as to why you want to use a different medication or a branded medication. So that's a challenge for sure among retina specialists, being able to prove to the payer why this patient merits a different treatment.
Yeah. So, and again, I think as treatment options evolve and even just treatment considerations and how the evidence is showing extended therapy can still be effective, I think is super important and helpful for those, especially patients that are significantly affected by, social determinants of health and, have transportation vulnerabilities and access to specialist all of those, access to care, all of those things. Well, let's conclude the case here, and we're going to finish up with our patient. So we see that the ophthalmologist's request for the anti-VEGF agent was approved based on her disease severity at baseline and documentation provided by the physician that the visual acuity had improved to 20/60 in the right eye and 20/30 in the left eye after 6 months of therapy. At 1 year, visual acuity had improved to 20/40 in the right eye and was maintained at 20/30 in the left eye. Her ophthalmologist adjusted the dosing interval to 6 weeks and continued to monitor and evaluate going forward. So do you have any final thoughts on this case and its conclusion?
I think we've got a good conclusion. I think we've helped the patient. Vision has improved. I think it's very important to make sure the patient understands this is a lifelong, an ongoing type of at least monitoring. They may not have to get treatment forever, but they have to be seen by, the ophthalmologist, the retina specialist for surveillance exams. And so I think that's really important to emphasize, importance of adherence to follow-up. Loss to follow-up is something we deal with among patients that can lead to vision loss.
All right. Well, thank you. I appreciate your insights on all of that, Dr. Scott. And why don't we open it up and see if we've got any questions from the audience? So, Dr. Scott, I mentioned it earlier in the discussion that data is pointing to increasing incidence of diabetic retinopathy in younger patient population. Is that something that you've seen in your own practice? And in the geographic region that you practice in?
Yeah, for sure. That's a great question. I think that all around us, we're seeing more and more individuals affected with diabetes and then the complications of that. And certainly in a practice that has a good proportion of patients with diabetic retinopathy, we definitely see more patients being affected by it, even at a younger age. So, certainly so.
And does that change your approach to how patients might need to be treated? Again, recognizing that they're going to live longer with this disease now, how does that, or does it change how you approach a patient and think about treatment needs for that patient population?
That is a great question. I think it has been a challenge for the healthcare system and all of us who deal with patients with chronic diseases, particularly diabetes, because we talked about the increasing prevalence, but you also have a condition that strikes individuals at a younger age. And it's really important to emphasize as a retina specialist that this is an ongoing, lifelong condition that will never be cured. A lot of times you can stabilize it, you can improve it, but we want to make sure that the individual themselves know that they need to be surveilled and monitored regularly with a dilated eye exam by an eye care professional, particularly an ophthalmologist. Our treatments are great these days, and we're doing more and more things to preserve vision or improve vision. But those individuals have to know that even though the treatments work, they may not last, and they have to be followed regularly. I also am impressed by some of the teamwork that it takes really in a multidisciplinary fashion. First of all, it lies with the patient to really help them understand the condition. Second of all, I mean, of course, the eye care professional, kidney specialist, and cardiologist, for example, too. But the primary care doctor has a great role in being that touch point for the person to help them understand the disease, and that these multidisciplinary appointments are important and important long term.
So speaking of or thinking, you just brought up a thought I had about just again the coordination within a multidisciplinary team. Are there things that payers can do to help support that approach and make sure that patients are getting access and being able to have all of those needs met by the various care team members of the care team?
Yeah, I mean, I think it is really important for us to make all of the things that we just talked about be as easy as possible for the patient, because if they have to access several of us, even primary care doctors or even some specialists, a lot of times they can get hit with a lot of waiting and a lot of red tape and a lot of issues even getting into see the physician for either primary or specialty care. So as payers, we can make it as user friendly as possible for the individual. So, for example, helping foster the communication, helping, rather than having to dig for, oh, who's your primary? Oh, not sure. Okay, tell me next time. Okay, we're not sure. What's their number? Do we have that? Not sure. So a lot of that, unfortunately, is a barrier to the communication that we need to all have. So perhaps facilitating communication among the team and really helping the patient to understand, and if there's any way to incentivize the patient for regular care, making sure that the patient knows that there's some benefits to preventing a catastrophic outcome in diabetes, sometimes even financially. I don't know if we can offset copays or we can have some sort of bonus programs for those patients too. So these are ideas that may help the patient themselves.
So when a patient's coming in and let's say they have other comorbidities, this is a question that's come in from the one of the attendees. If the patient is on more than one biologic agent treating, say, another condition, are there any specific concerns you have or things that you look for that would prevent the use of one of these agents?
Yeah, that's a great question. And there's certainly certain agents that are very well known to have adverse effect, for example, potentially on the eyes or even vision care. And, these agents are exploding faster than we can kind of keep track of the particular side effects that we have to look for. So, for example, hydroxychloroquine is the trade name Plaquenil. So there's a known retinal toxicity in patients that use it regularly, and it's used for a multitude of diseases, usually, immunologic conditions, autoimmune conditions like lupus or rheumatoid arthritis. But there are certain things, if a patient is on it for decades, that we as retina specialists need to do as far as imaging and documentation of certain testing. Now, there are other things like the oncology in the oncology space. I mean, the chemotherapy agents, for example, are coming out so quickly. It's hard to even track exactly what side effects with the eyes have been described and what you're particularly looking for. So I try to we try as ophthalmologists to stay on top of, the key pharmaceutical agents that are being used and what adverse eye side effects. Like, for example, one oncology medicine for breast cancer causes dry eye and is known to do so. So, for example, we just try to stay on top of those things and be aware of what we're looking for. And these things happen and change so quickly, and sometimes you have to look up what a medicine is and what it's known to cause. So really just trying to be abreast of things in the literature. And when in doubt, I always go to, follow the patient more closely. If they're on a medicine, you don't know what it could do. Make sure they follow with you so you can at least follow their exam and their imaging over time to see if anything's worsening or they're having any sort of effects.
So after patients have been on therapy, if you're not seeing results, what are like the next steps or things that you might do as medications may be showing not optimal treatment to where you'd like to get a patient or where a patient would like to be?
Sure. So, the first thing I try to check my regimen. Are you treating the patient as frequently as they need to be treated? So sometimes you can do a disservice to a medication, or you won't really know if it works or not if you're not using it really on as it's supposed to be used, or maybe you're using it more infrequently. The patient, you were supposed to see them back in 6 weeks, but they came back in 3 months, and they're like, "Oh, this medicine doesn't work." And the question I have is, gosh, if we had done it a little bit more consistently. So, for example, a lot of these anti-VEGF medicines we were talking about using for patients with diabetic retinopathy, I typically recommend at least 3 doses each month apart to kind of, have a maintenance or induction phase. And then after that, you get the maintenance phase in which you can sometimes extend the patient. So, for example, just making sure that you are using the medicine as it's intended to be used. Because I think if a medicine is studied monthly and you're kind of giving it every so often, it's not really giving the medicine or the patient the best chance. But then if I feel like I know that I've been trying to use this medicine on label, and or at least as I think the half-life it should be used, then sometimes I'll change medications. And of course, we need payer permission to do so. But if I can, I'm starting to look after the first 3 doses or so. You're not responding as well to this medicine. Could another medicine be a little bit more durable? Because I know you may have the challenges coming back, or your disease may be a little bit harder to control. So we may look for a different medicine. And so I'm always starting to think of how can we do better? How can we do better? Is it me? Is it the patient? Is it the frequency? Is it the drug? So I'm always thinking about, what's the next step if we don't have as much efficacy as we want.
Well, Scott, I just want to say thank you so much for your discussion and your insights that you provided today. But I'd like to conclude the webcast today. And once again, I want to thank Regeneron Pharmaceuticals for their support of the program today. To claim credit for the activity, please click the complete evaluation link. Once the evaluation is submitted, you'll be able to select the type of credit that you require, and you have to claim your credit to receive the certificate and for pharmacists to submit to the CPE monitor. So please make sure and fill that out so the Impact Education team can get feedback on the session. And again, this concludes today's webcast and discussion. And thank you so much again, Dr. Scott. And I hope everybody who joined has a great rest of your day.